Johns Hopkins Medicine.
Known for groundbreaking research, teaching, and medical care.
Hello and welcome to Johns Hopkins Medicine Facebook Live. I'm Dr. Seth Martin, Director of the Advanced Lipid Disorders Program and Director of the Digital Health Lab at the Chickaroni Center for the Prevention of Cardiovascular Disease here at Johns Hopkins Hospital. I'm joined by two amazing colleagues, Dr. Bill Ravix, Director of Pediatric Heart Transplant and Mechanical Circulatory Support at the Blaylock Taussig Thomas Pediatric and Congenital Heart Center at Johns Hopkins Children's Center. That's a long one, Bill. And Dr. Lena Matthews, Director of Cardiac Rehabilitation and one of our leading cardiologists. Thank you both for being here. I'm looking forward to a great conversation.
Good morning, pleasure to be here.
Hey, good morning, Seth. Very much looking forward to this.
So let's start off just with some introductory statistics. So we're going to touch on a range of issues, including conditions that affect both adults and children. We're really going to cover a wide range here. We're going to cover tips to keep your heart healthy and what the recovery process looks like if you suffer a cardiac event. And of course, if you have a question, please send them in. Please leave your comments. We'll do the best we can to answer them during this discussion. But first, why is it so important to focus on our heart health? Let's cover some of these key statistics. So heart disease is the leading cause of death worldwide, claiming more lives each year in the US than all forms of cancer and chronic lower respiratory disease combined, accounting for 19 million global deaths in 2020. Usually our statistics are lagging by a few years because it takes some time to collect the statistics, clean the statistics, analyze the statistics. So often when we talk about them, they're a few years behind. So that's from 2020. And the numbers are not improving. While in recent years, heart disease deaths started to decline, we're starting to see an uptick again, with deaths surpassing the previous high of more than 900,000 in 2013. So let's dive into kind of the reasons for that some, and we're lucky to have Dr. Lena Matthews here to give us some insights into the reason for this. So what may be some of the reasons why we're seeing the increased numbers of cardiovascular related disease deaths in our country?
That's a great question, Seth. And if you look back over the last 40 years, we've made immense strides in reducing cardiovascular disease. We know that tobacco, high blood pressure, high cholesterol all contribute to cardiovascular disease. And we have amazing technology, amazing medications that have resulted in substantial declines. But as you said, over the last few years, we've seen rising cardiovascular deaths. And it could be attributed to a few things. I think the first one is what we see is a worrisome trend in rising obesity rates in our country. The CDC estimates that 42% of Americans have obesity, and the trends can continue to increase. And as a result, people with obesity are higher risk of diabetes, which puts people at risk of cardiovascular disease. And people with obesity also develop other complications. So that's one reason. The second reason is the COVID-19 pandemic. And it affected cardiovascular disease in a couple ways. First, COVID-19 results in inflammation, increasing risk of clotting. And as a result, people with COVID-19 present with heart attacks and strokes. And also, people who had cardiovascular disease that was stable, especially in the early days of the pandemic, were less likely to go to their doctor, seek preventive care, and present it to the hospital when it was too late. And then the last thing is what we call an implementation gap. We have amazing technology, medications, but there's a substantial group of people who don't benefit from them. They don't receive the therapies that they're supposed to. So working together to close the implementation gap. So these are some of the reasons why we're seeing the rising rates of mortality.
Yeah, thank you, Lena. That's really insightful, and clearly we have this is a call to action to really come together to address the obesity, diabetes epidemic as a public health crisis, as well as to really now pick up the steam after the COVID pandemic has really taken a toll, and to close these implementation gaps that we're seeing. And it's about working in our adult populations, but also in our pediatric population. So I think we'll turn take the next question to you, Bill, about turning towards children. And amazingly, heart disease can be diagnosed even before birth or in infancy. And so how prominent is congenital heart disease in the US, and what are some of the signs that we should be looking out for?
So for us in pediatric cardiology, we kind of have two groups that we look at. One is the idea of congenital heart disease, or heart disease that you're born with. And this is mostly looking at structural heart problems, a hole in the heart, a valve that's not working, or actually completely missing one of the chambers or blood vessels of the heart. It's very common. 1 out of 100 babies will have something structurally go wrong with their heart. And this can range from very minor problems that may never actually need any intervention to very serious problems where you might need a surgery or a cardiac catheterization within the first few days of life. But in general, about 1 out of 100 children will have a congenital structural heart problem, which makes it one of the most common congenital lesions that we see compared to other things that can happen for babies. Many of them are prenatally diagnosed, unfortunately not all, but with good prenatal care, OB care, maternal fetal medicine care, that helps. Getting back to the obesity epidemic, certain things on the maternal health side, though, can increase, unfortunately, the risk for the baby to have a congenital heart defect as well, and obesity is one of those risk factors. If babies who are not diagnosed before they're born, though, they'll usually be diagnosed as a newborn. Now, certainly here in the state of Maryland and most of the US, we do what's called congenital heart disease screening. It's a very simple check. We check the oxygen level for the baby's hands and feet before they go home, and that will help us find those many of those congenital or structural heart problems, not all of them, but many of them, especially the more serious ones. And then later we'll talk about, for within pediatrics as well, our concern for acquired heart disease, secondary to obesity or to other complications.
Thanks, Bill. That's super insightful. And I think part of the message is early, making diagnoses early, getting started on heart health early. But unfortunately, we do see disparities across different racial, ethnic groups. African Americans and minorities are disproportionately affected by heart disease. So I wanted to turn to you, Lena, to really speak to this. Why are we seeing these racial and ethnic disparities?
That's a great question. We talked about the statistics earlier, the rising trend in mortality. And if you are to look closely at the numbers, you'll see that, yes, African Americans and other racial and ethnic minorities are disproportionately affected by cardiovascular disease, are more likely to die from heart disease, more likely to present at earlier ages, and when they present, have worse complications. And why is that? I think one of the big things is the structural inequities that we have in the health system in terms of difficulties getting high quality health care, getting high quality preventive care, difficulties in getting fresh food, and also in areas for physical activity. So it's just structural inequities may be contributing to these disparities that we see. And then it's trustworthiness in the health system. So potentially some individuals are less likely to seek care because of the trust that they have or trustworthiness in the health system. And as a result, we may see these disparities that are occurring.
Yeah, thank you for shedding light on that. And clearly, this is something that has to be a top priority, really, in every program and that we're working on to improve the health of our country, putting equity first and really making sure we're designing a health system that can work for everyone and public health systems that can work for everyone. So let's talk about what we need to look out for. If someone's first just wondering if some symptoms that they're having could be related to heart disease, what do people need to know today as the first signs and symptoms, or even just risk factors, even before symptoms occur, risk factors that predispose to potential heart concerns in adults and children? Maybe, Bill, you want to start off, and Lena could chime in then as well about the adult population.
Sure. So for now getting into more the acquired heart disease concern, what can happen in general, of course, going back to obesity, physical activity, and exercise. And I'm going to go in a second on one of our graphics. We're going to talk about how those can be worrisome things for triggering a heart problem, but I don't want people to take the wrong message of therefore don't exercise or don't be physically active. No, definitely encourage regular physical activity, being active, being out there. But there are some children who are going to have a heart problem, and it may not be secondary to obesity, but it may be from an intrinsic concern within the heart itself, something that's not going to be picked up prenatally or with that newborn screening. And so these are more subtle problems, either with over time their heart muscle has gotten too thick, or they have a coronary artery problem, a little different from adults, not usually cholesterol related, but a structural one that's hard to see that appears. So some of the signs and symptoms that we look for are going to be kind of, is it cardiac chest pain or is it non-cardiac chest pain? And you're still feeling pain, you're just reacting to something else. So our signs of non-cardiac chest pain are going to be something that's really sharp, quick, but then goes away very quickly. Another sign of non-cardiac chest pain is one that occurs more sitting down, reading a book, watching TV, but not during very vigorous physical activity. Non-cardiac chest pain in pediatrics, if it's reproducible, if I can push on your chest and it kind of feels the same, or if a parent can push on, oh yeah, it feels the same, more likely something coming from the muscles, the ribs, something on up there. Or when they come to the clinic, if it's something where I'm talking to the child and their parent and they don't bring it up. It's kind of when I'm going through then my list of questions, oh, have you ever had chest pain? Oh yeah, once. Those are ones that we're less worried about. Flip side, what are we worried about? Ones that occur during vigorous physical activity. If a kid is running, playing their favorite sport, running down the soccer field, and all of a sudden they stop because they can't keep going, it hurts too much. That's a very worrisome sign for us. Much like in adults, kids also say kind of this feeling of doom, like, you know, how worried were you? Oh, I was so sick, I felt so very worried. Another worrisome sign for us that it's going to be, again, something coming from within the heart and being a kind of cardiac chest pain. Other signs we'll look for, the same similar kind of radiation throughout, the sharing the nerve endings. And then for kids, the littler baby, not the little babies, but the children, if they're having impaired cardiac output, another thing that children will often present with is abdominal pain. When the heart's not beating strong enough and it's not getting good blood flow everywhere, it's not getting to the stomach and the intestines. And so kids will sometimes come in with chest pain, but at the same time they're having a lot of abdominal pain. They're not eating well. Those are signs to us that this is coming from the heart as opposed to coming from somewhere else within the chest.
Thanks. That's super detailed and insightful. And I think, you know, if you are having these types of symptoms concerning for cardiac disease, it's, you know, we certainly encourage everyone to get checked out. Even if it turns out to, as you get tested, to not be related to heart disease, at least you can learn about your body and possibly identify risk factors early so that you can prevent such symptoms and cardiac disease down the line. You might find that you don't have cardiac condition at the moment affecting the heart, but you have high blood pressure, hypertension, which long-term could cause damage of the heart. And so there's so getting kind of connecting with the medical system, learning about what risk factors you may have is always useful.
Absolutely. The majority of chest pain in children and adolescents, less than 5% or less, is actually going to be coming from the heart. But we do encourage people, especially if you have some of those symptoms I talked about, to come. One, because the things that do come from the heart can be devastating and we want to identify them. But two, being engaged with getting good medical care, starting to talk about secondary things such as blood pressure, weight, regular physical activity.
Take it as motivation to get engaged in that way. But it is worth differentiating between men and women. Women can present with symptoms that are different from men. So Len, I wonder if you could speak to that, the unique symptoms that women may present with.
That's a great question. You know, studies have shown that 80% of men and women present with typical chest pain. So the chest pain that Bill described, central pressure crushing pain. But as you said, women can present with atypical symptoms. So some symptoms that women can present with are palpitations, so feeling like your heart is racing, just generalized fatigue, abdominal pain, or just not feeling right. And some women present with silent symptoms when they're having a heart condition. And more importantly, women are less likely to perceive that their pain is related to the heart. And I think it's because of not knowing that they have risk factors. And then when they seek care, the health system is less likely to think of women as high risk. And you know, women may have additional risk factors, so risk factors that occur during pregnancy. So if they had high blood pressure during pregnancy, diabetes during pregnancy, all these things put women at risk of future heart attacks, and so they may be under-recognized. So these are some ways that men and women can be different.
Thank you for sharing that. And you know, and I know that we do sometimes describe them as atypical for women, but they might be typical for women, as we need to kind of be mindful of the way that men and women present with heart disease. And thank you for shedding light on that. Let's interrupt our kind of usually scheduled questions here for a Facebook question from one of our listeners, viewers. So we have a question about statins. If you can't take statins, what are some of the things to lower cholesterol? Would either of you want to jump in on that? I'm happy to chime in as well.
Well, I'll start from the pediatric standpoint, and we will start statins when we need to, but usually once you start a statin, you're kind of on it for life. And it's one thing if you're starting it when you're 60, 70 years old. It's another thing if you're starting when you're 16.
Right.
So going back to diet, of course, but then regular physical activity. Physical activity is really, certainly for our adolescents who have borderline cholesterol levels, can really do a fantastic job about helping bring down that cholesterol level.
Okay.
Great. And there are additional medications that are not statins that can lower cholesterol. So there's ezetimibe, has been shown to reduce cholesterol, and then there are newer medications, PCSK9 inhibitors. These are injectable medications that you can take every 2 weeks or once a month that have been shown to substantially reduce cholesterol and also reduce the risk of having heart attacks in the future.
Right. Thank you so much. That's really helpful. And I will, I guess, chime in a bit more because I do direct our lipid clinic. I'd like to give a plug. We do have a lipid clinic, and we often see patients who've had trouble with statins in the past. That's absolutely right. Our guidelines recommend ezetimibe, PCSK9 inhibitors as options. These medicines generally work by upregulating, increasing the receptors in your liver, the LDL receptors, to act as kind of garbage trucks to clear out LDL out of the bloodstream. They work in different ways, but ultimately that's kind of the central way that they clear cholesterol from the blood. There's a new medicine called bempedoic acid, which also can be combined in a fixed dose combination pill with ezetimibe. We're going to be going to the American College of Cardiology meeting very soon, where there's going to be a big clinical trial presenting the clinical outcome results for patients that took bempedoic acid, which so that's a newer medicine. And there's also a medicine called evanicumab, which is used in patients with familial hypercholesterolemia, which leads me back to what you were saying about the pediatric population. It is very important to the theme of diagnosing early to look out for kids who have familial hypercholesterolemia, meaning they were born with a gene mutation that raises cholesterol, particularly LDL cholesterol levels, up to very high levels from birth. In that group, it's well accepted to start statin medications as well as possibly other medications in childhood, often beginning around age 8, if not earlier than age 8 in certain patients with severe forms of familial hypercholesterolemia.
No, absolutely agree with that. And there's another rare subset of patients that I happen to follow, though, the heart transplant patients, where we also want to be very protective of the heart, and we will often start statins at a young age. And I do want to emphasize they are safe for children. They, like any medicine, we look for the side effects, but the idea of, can I not start this? Is this an unsafe medicine for my child? No, absolutely not. The risk from the cholesterol is far more risky than anything from the medicine.
Right. I think that's a good point to emphasize that they're really well tolerated, very safe class of medicines. It's statins are one of the medicines that we've studied the most over it's one of those medicines that just for decades we've accumulated this huge amount of evidence. They really are well tolerated and safe. I would say to the question around non-statin medicines, kind of one of the first thing too is to really be sure that you've tried statins, because there's a bunch of different statins and doses you can take, and we often find that if someone had trouble with one, if they just try a different statin or dose, that they do fine with that. So that's worth thinking about. But it looks like we have another Facebook question. So what exercises, and I think I'm going to direct this one to you first, Lena, what exercises are good for cardiovascular health for someone who can't do strenuous activity?
That's a great question. So for people who can't do physical activity because they're limited because of their heart disease, have just had a heart event, for example, heart surgery, heart valve replacement, there's a program called cardiac rehabilitation. And this is widely available throughout the country. It's covered by insurance. It's an outpatient program that has supervised exercise. So you come in, you're given an exercise prescription, and are monitored through your initial exercise. And you're progressed until you're able to exercise on your own. So you're really given the confidence to be able to exercise on your own in the future. And it's a comprehensive program because it not only does exercise, but we also do education about risk factors. We do education about medications, see if you're having any side effects, assess your psychosocial level, and see if you need any referrals for any counseling. And what cardiac rehab has been shown is that it improves your outcomes. So it reduces mortality, reduces the risk of having a future cardiovascular event, and improves disability. So you're able to get back on your feet, get back to work after a heart event.
Thank you. Yeah, this is such an important program, and we're thankful for your leadership of our program here at Johns Hopkins. Anything you wanted to add from the pediatric side?
No, the biggest thing I find for my patients from the pediatric side is I don't try to specify which activity. Whatever the child wants to do, whatever they're active and willing to do, but the idea of doing it regularly and getting into a good habit. And it's a good habit then hopefully you carry forward all of your life of doing a regular activity and physical exercise. But the idea that on Saturday I'm going to work out like crazy and then spend the rest of the week not doing much, that's more of a challenge. So getting into regular activity, again, find what you're motivated, what you enjoy doing, and then doing it regularly.
Thank you. So this conversation has been fantastic. It's flown by, and we're already up to the end here. So I'd like to end with some heart-healthy tips, leave our audience with kind of very actionable information about heart-healthy tips for adults and kids for the entire family. So the American Heart Association recently released Life's Essential 8, which are really the critical ingredients to preventing cardiovascular disease throughout the lifespan. This includes eating better, being more physically active, quitting tobacco if you are a tobacco smoker, getting healthy sleep. That was a new addition to the to HA's paradigm here. Managing weight, controlling cholesterol, managing blood sugar, and managing blood pressure. Did you each want to add a little comments to this?
I think those are all great, and for people who've had a cardiovascular event in the past, the ways to prevent a future event is things like cardiac rehabilitation as a way to get back on your feet and get strong again and get your heart ready for exercise.
I agree, those are excellent things. One thing we'll often joke in pediatrics is that children are not small adults, but as far as these recommendations, absolutely, these recommendations for adults very much apply to children too. And for that quitting tobacco thing, well, one, never start, but we try to emphasize a lot vaping as well. Vaping is another thing that can be very bad for your heart health as well as your lung health and your general health. So I would say that, again, love those 8 recommendations.
Thank you. Yes, I mean, starting early is so critical because we know that when it comes to these risk factors, it's about the cumulative exposure. It's not that you've had this risk factor for a year or two, but over a long duration of time, that's where the risk accumulates. So the more we can address these risk factors starting in youth, the more successful we're going to be in cardiovascular disease prevention. So thank you, Dr. Bill Ravix and Dr. Lena Matthews for talking today. This is a great conversation. Thank you so much. It's always great to see you both and have this time to share about a very important heart topic during Heart Month. Thank you for watching. To our listeners, we hope you enjoyed it and encourage you to follow Johns Hopkins Medicine here on Facebook and our social media platforms. And to learn more about heart health and tips on keeping healthy, please visit hopkinsmedicine.org/heart. And for pediatric needs, please visit hopkinschildrens.org/heart or call the numbers on your screen to make an appointment. Thanks again. Stay healthy. Happy Heart Month to everyone. Thank you so much.
Thank you.